We have 4 minutes for this session. What we're going to do is I'm going to let the poster presenters introduce themselves and the title of their poster. They have 5 minutes for their presentation and 2 minutes for questions. They can mix and match. So if we don't get to your question about the poster, please feel free to contact the presenter directly by using the Event Moldy application under the attendees tab, or send a message on the presenter's profile page. And it's very, very important. We really want everyone to go online and to vote for the People's Choice Poster Award to find on the Event Moldy app. And so thanks again for attending, and we'll let our first speaker speak. And there we go. Ready?
Good evening, everyone. My name is Cassandra Bravo Rodriguez. I'm an undergraduate student at the University of Virginia School of Nursing, working with Dr. Emma Mitchell for this past year, and I'm delighted to speak to you all about our work on culturally, linguistically, and regionally tailoring a patient-centered telebehavioral app to increase access to community-based cervical cancer preventative service in Bluefields, Nicaragua. So just a little bit of background about cervical cancer. The World Health Organization has committed to reduce cervical cancer by 1/3 by 2030. Nicaragua has one of the highest incidence rates of cervical cancer in the world, with the Caribbean coast having this higher incidence than the rest of the country. UVA has had a long-standing partnership with SEDECA, which is a non-governmental organization in Nicaragua that seeks to promote education and address health disparities in the Caribbean coast. In collaboration with SEDECA and the Nicaragua Ministry of Health, a need was identified to provide education on cervical cancer prevention in Bluefields, a Caribbean coastal town. An mHealth approach was decided to be the best way to implement this, as it would reach the greatest amount of people, and it would also be able to be conducted remotely. In the summer of 2020, focus group surveys and interviews conducted with community members in Bluefields determined that Android would be the best mobile operating system for our app Azulado, and that password features would need to be implemented to protect the privacy of users. And we also conducted a survey to determine how much the cost burden of the app would be based on cellular data usage and the cost of cellular providers. So then Azulado was created through the collaboration of UVA app developers, researchers at the UVA School of Nursing, community members in Bluefields, and personnel at SEDECA. Every component of this app was created with some sort of input from community members. One of the key features of the app were the historias, or the stories, which were culturally tailored stories that featured 3 women created to represent the women from the Bluefields community. These stories showed 3 different stories about these women's path to cervical cancer testing and how to navigate the different stigmas surrounding cervical cancer and how to deal with the positive or negative results. We included articles and videos about cervical cancer prevention, cervical cancer, about the disease itself, about diagnosis, treatment. A discussion board featured allowed users of the app to communicate with each other, share resources, and just create a community of women in Bluefields. The app's language setup could be changed to either Spanish or English, although most users use Spanish, but these were identified as the 2 most popular languages in Bluefields. After Azulado was piloted in the summer of 2021, we conducted focus group interviews with testers to review their feedback. The interviews were conducted in Bluefields by SEDECA in Spanish, and then the UVA team analyzed the information and remotely. So thematic analysis of the qualitative data was conducted in Spanish, then transcribed. And these key findings were used to make improvements to the app, as well as address the feasibility and effectiveness of the app. We found that the participants appreciated the convenience of the app's layout, the ease of navigating the features, and the availability of information in the app. They did make some key recommendations, which was to modify the login process as many users had a lot of trouble, adding more resources, more information about cervical cancer, and also implementing more specialized features to individualize the app to make it more attractive to users. Participants agreed that Asulado was a helpful app with relevant information about cervical cancer, and many expressed a need to share this information with other members of their family or community members. So with this data, we found that the app was effective in creating and increasing cervical cancer awareness in Bluefields. There was overall satisfaction from participants with some recommendations on technical changes. We created this app in close partnership with community members and key organizations in Bluefields. The app created a network of peer educators by educating users on cervical cancer, and then these women sharing this information with friends and family who might not have access to Asulado. We identified this was an important tool to reaching medically underserved areas to address health disparities, and identified that Asulado could have the potential to contribute to the World Health Organization's commitment to eliminate cervical cancer by virtually educating patients about screening. Our future plans include to continue to conduct research for future updates and to possibly implement the app in other areas after carefully assessing the community and adapting it to the specific needs of that area. Thank you for your time, and I'm open to any questions.
The three women in the app, the three stories, were those real women's stories, or were they sort of created? Were they fictional?
No, they were created in collaboration with community members and also SEDECA. People in the focus group interviews actually thought that they were real women. This is how relatable they were. They thought that they were real women, and they were concerned with their privacy because we showed pictures, but they're just stock photos. We showed pictures and their names, and they thought that they were real women, and expressed a need to protect their privacy. So we created these stories with, in collaboration with community members.
And did you provide any incentive for people to use the app?
No, we did not. SEDECA they already have a network of workers and volunteers and community members. So we used their resources. They identified members of the community who thought would be able to test the app and give us feedback. And that's how we recruited users.
All right, that's 7 minutes. Now, if you have more questions at the end, because so far we have one speaker that hasn't shown, so we may have a few extra minutes at the end.
Thank you.
Thank
That
you
was
very
great.
much.
Thank you.
Here we can go to our next presentation. Live. It's not been Rex this time.
So I'm Anna DeKalf Dorsey. I'm a licensed clinical social worker at Kennedy Krieger. I'm also the program manager for the Department of Telehealth there.
I'm Brianne Jones. I'm the program coordinator in the health department at Kennedy Krieger. So Kennedy Krieger Institute is a children's hospital in Baltimore, Maryland that provides comprehensive specialty care for children and adolescents with a range of behavioral, emotional, developmental, and physical challenges. And today we'll be talking about our Telehealth Technology Access Program. So like many healthcare facilities, when the COVID-19 pandemic hit, Kennedy Krieger had to abruptly switch from predominantly in-person service delivery model to predominantly telehealth. So from the week of March 8, 2020, Kennedy Krieger provided only 13 telehealth sessions, but just 3 weeks later, we provided over 4,200 telehealth sessions. And during this transition, we found that many of our established patients weren't able to access care via telehealth due to lack of a device, insufficient internet connectivity, or both. So So to address these barriers, we applied for and received a grant through the Federal Communication Commission's COVID-19 telehealth program. We used these funds to purchase iPads and hotspots that we were able to distribute to families so that they would be able to access telehealth.
All right. I'm going to talk a little bit about what we found during the project. And the poster, you can't quite see it, it's called the Kennedy-Krieger use of technology to address health, Kennedy-Krieger's use of technology to address health disparities. I'd like to say that all of this data is from March 30th. It goes up to March 30th, 2022. So we had over 400 patients receive one or more device. Now we have a lot of families that have multiple patients in the household. So we really actually were able to reach a lot more people than that. Our providers were the ones who requested the devices for our families. And this was a really nice opportunity for the providers to be able to take a more holistic view of what the family's needs were besides just what was going on with their particular discipline. You can see over here that most of those requests, or a large portion of those requests, were from behavioral health. We also had a large portion from therapies, especially speech and language services. And I think this makes a lot of sense because these are some of the providers that are going to see kids week after week after week after week. But because so many of our patients do receive multiple services, we really were able to facilitate a lot of medical appointments and appointments for other disciplines as well. So we were able to provide devices in 21 counties in Maryland, Washington, D.C., and Virginia. When we went into this, we assumed, as we often do, that rural, that's where people are really going to need these devices, really going to need this internet connectivity. But what we actually found is that 55% of our devices went to Baltimore City. So what we were seeing was that there were a lot of families that were doing telehealth on maybe the one smart device that the family had, or they had internet, but they didn't have enough for multiple children to be in virtual school and also to be doing telehealth visits. You see patients who sometimes multiple families living in a home, or there are a lot of children in the home, so it can really put a strain on your internet connection. So one of the things that we were very proud of from this program was that we were really able to address financial barriers to telehealth. 39% of patients in Kennedy-Krieger are in medical assistance, but in this program, we had 90% of the patients were eligible for medical assistance. So we really were able to target people who didn't have the funds otherwise to get these devices. We also were able to target language barriers to telehealth. So 17%, or 3% of patients at Kennedy-Krieger report Spanish as their preferred language, but 17% of our devices went to families requesting materials in Spanish. We learned a lot from this program. We learned about barriers to telehealth. We learned that urban communities were affected versus rural, financial, and language. The other thing that we learned is that you really need institutional support to make a program like this work. FCC grant was amazing. We got to get so many iPads and so many hotspots and services for the hotspots. But Kennedy-Krieger also had to supply the cases and the instructional materials and translating those instructional materials into Spanish, and just the person power that was involved in setting up these devices, distributing them, and then providing technical assistance once the families actually got them. So we really feel that telehealth can really help with a lot of these access disparities, but you need the buy-in from, the buy-in and the funding from your institution in order to address them. Any questions?
Did you guys, when you sent the devices out, was there an expectation that you guys were going to get them back, or were they given to the people that were participating permanently?
So it is a loaner program technically, but I will say that we understand that some of those devices will come back and some of them don't. We've had some of them come back, and we're kind of pursuing seeing if we can get more back just so we can give out more to more families. But we made it very clear when we gave them out that they're like, if you lose it, if it gets stolen, if you just can't give it back, there's no penalty. Because we had families initially who were afraid to use it because they were afraid there'd be a penalty if it was harmed.
How did the hotspots work out as far as the data availability? Did you guys find that was sufficient for providing these services? Did you run up against limitations with that?
That is a great question, because it really is, we have hotspots from Verizon, and if you had good Verizon service, they were great. In a couple areas where people did not have good Verizon access, it did not work as well. So it would be better, I think, it would be ideal in a program like this to have a variety of carriers.
We also had, we put some restrictions on it in terms of what you could use the hotspots for, right? Just to kind of protect against that data limit. But we never had, other than that, we never had families like contact us and say that they weren't able to do their telehealth session because of it. But there were just some streaming things that we had to limit because we had a pool that all of our families were sharing.
Okay.
Yeah, absolutely.
Nice work.
Any questions on the following? Good. Richard? You got
Do you want to do it?
No, yeah, I'll do that one.
Yeah.
Thomas?
There we go.
There we go.
I had a heavy finger.
Yeah, I got the word for the most wordy poster. Being an engineering background, I think that kind of drove to this. We also tried to get the longest title award. So, telemedicine, isolation, communication management systems, ISOCOM, beyond the biocontainment unit for improved experience, safety, and lower resource utilization during COVID-19. We began this work back in 2014, focused on Ebola rollouts at the hospital at UVA Health. We were designated as by the Commonwealth of Virginia and the CDC as a COVID treatment center within the state of Virginia. Prior to that, we had been meeting with some doctors that were visiting from Africa. We had a very interesting problem that we found as we were talking to them. Interesting to us as engineers trying to solve a problem. When patients would go into isolation for Ebola treatment, it was the last time that they got to see a human face. After that, it was all PPE. They no longer got to see their families anymore. In these communities, this is a very tight-knit where families are important. And so they were basically being cut off from that beyond once they went into isolation. So us as engineers started to put our head together, and this is very resource-limited environments, and we designed a system using birdhouse cameras and little small portable car video screens that could be placed inside and outside of the isolation areas with about 300 foot of cabling so that families could come up to that isolation area and have a conversation with the patients. Very rewarding work for us as engineers to feel like we're helping people get connected. Fast forward a few months in 2014, and all of a sudden we started to see our first Ebola rollout patients in Charlottesville. Luckily, the first two we saw were not positive Ebola, but all of a sudden we started to look at how we could use our internal resources to provide services for these patients in the hospital. The initial idea was to lower PPE usage to go into the spaces. So nurses donning and doffing, it takes about 20 minutes to put on that PPE, and it takes about 30 minutes to take it back off. So really, you are very isolated when you walk into these spaces and you have very little support staff around you. So we found by utilizing some of our video systems within the hospital, we placed Cisco WebEx systems inside the patient rooms, and then we had iPads and different devices outside of the patient rooms, and we provided a level of service so that you could have a conversation with that patient prior to entering the space. One of the very first times that we had the usage, we followed the patient when they showed up at the loading dock of the hospital, because that's where we brought in Ebola patients. We followed them all the way back up to the room. And then the doctor was having a conversation with that patient, introducing himself prior to going into space. It was a very heartfelt moment. The only problem I had is we hadn't done a lot of work with camera placement, and the top of his head was cut off while he was talking to the patient. So it was interesting, and I wanted to kind of chime in and say, hey, turn your camera down. But it was just a very heartfelt moment where he was introducing himself to the patient. Fast forward to March of 2020, we had all of these systems in place. Still in our biocontainment unit, we were limited to just 2 rooms because Ebola was a very small set of patients that we worked with. We started to receive our first COVID rollouts in March of 2020, and we expanded from 2 rooms in the biocontainment unit to the full 8 rooms within the biocontainment unit to provide services. Beyond the lowering of PPE, we were able to provide specialty care in these spaces. So you could see many different docs. You could actually speak to social services. One of the interesting uses was nutritional services, speaking to these patients about what they wanted to eat. It's the little things that make you feel more comfortable when you're in the hospital and experiencing these things. So really, this is a lot of uses that we were using The other thing that we could do was to bring the family members into these conversations as well. So by having a video system within the patient space, we could easily turn that on and invite a family in, and they could be included in those conversations around the patient care. So, ISOCOM systems at UVA use a standards-based Cisco network. It's made up of WebEx systems within the patient rooms. We have iPads outside of the patient rooms. We have systems set up at many of the HUCs around the hospital. We have doctors that are carrying iPads, so everybody's able to access the patients very easily within spaces. When we started, or since we started, we did 1.9 million minutes of video communication in and out of those spaces, and it's become an integral part of all of our inpatient care around these patients in the hospital. The number of rooms have expanded from the 2 that we initially started with. During the COVID pandemic, we were racing to outfit rooms to stay out in front of the surge as it was happening. We ended up building out about 149 rooms within the hospital systems. So some of the things that we were looking at as far as our outcomes was the lower usage of PPE. We were able to clearly show an advantage to having the people enter the space or go into the space less times. On average, the nurses will go into the rooms 3 to 4 times a day. And each time they go in, it costs about $3.20. If we have 10 nurses on shift for 2 shifts in a month, that ends up being about $20,000 in PPE for our acute floors. That's not including our medical ICU. So we had a direct cost savings of lowering the usage of PPE, as well as during the pandemic, when there was a shortage of PPE, we were able to lower the usage within the hospital. One of the unanticipated consequences of that was also the time savings that comes along with not having the nurses don and doff to go into the spaces. Again, it saves about 50 minutes per entry. And that is something that we were really not anticipated. It was a great cost savings that came out of it. Second was improved safety for both patients and providers by lowering the number of direct interactions within the infection control units. We were able to limit exposure and decrease the number of times that people could be exposed, as well as having safety officers monitor those interactions within the patient spaces. The third outcome that we came to was just the improved access and experience for both providers, because they could quickly dial into the space and kind of check in on the patients with just a couple of minutes. They don't have to put on PPE and walk into the space. So they would actually have more interactions with the patients. Patients having direct access to their families and being able to include them in those conversations also became an invaluable tool to us. So our conclusions are, it was a clear cost savings for utilizing these type of systems within isolation communication rooms. There's a large cost up front to get it started, so it's a complex conversation to look at a health system and how you outfit the rooms, but we see a huge value in the potential of having these systems built into the rooms in the very beginning, because they can be used for everything from this isolation type work to telesitting and a lot of other services that we provide in a very disparate manner. So we feel like if we can combine a lot of these systems and leverage one in the spaces that everybody's very comfortable with for its usage across the system. We haven't analyzed specific data to determine the impact on staff utilization, but there was a clear cost savings in the fact that we did not have to have as much time. Improved safety through lowering the potential exposures, access to supportive care resources. And then while there is some data and observations point to significant cost savings, we do feel like we need to do more work on that in the isolation spaces.
We ran over a little bit.
So sure, I can go into like a lot of detail around a lot of different things, so get into your report.
Let's see if Thomas Martin, did he show up virtually? If not, if it's okay, we'll go on and let our final presenters present, and then come back to you. If that's okay, Brian.
Yep, sounds good. Thank you.
Did you? All right, good.
It's hard to see it, right?
You can get up closer. It's not gonna hurt.
Yeah, for sure. My name is Mara Fuller. I'm a social worker at the Salem VA in Salem, Virginia. and I am the Advanced Care Plan VA Group Visits Program Coordinator.
And my name is Erin Sellers. I'm also a social worker, and I work at the Richmond VA, and well, it's also called the Central Virginia VA healthcare system, but I usually call it the Richmond VA, so you may hear me say that. But I also work with the Advanced Care Planning VA Group Visits Program.
And I think we were competing for a long title as well. So it's pivoting in-person advanced care planning groups to virtual platforms, piloting telehealth groups with rural veterans. So the Salem VA healthcare system, we serve about 43,000 veterans. So it's overall a pretty small facility, but we serve a lot of rural veterans. So overall, we have 59% of the veterans that we serve are considered to be rural or highly rural veterans.
And then at the Central Virginia VA, in 2019, we served about 170,000 veterans. We have 2 medical centers in that area, multi-specialty community-based outpatient clinic, and then 8 community-based outpatient clinics. Only about a quarter of our veterans are identified as rural.
In 2019, the Office of Rural Health provided or awarded Central Virginia VA Healthcare System and Salem VA Healthcare System funding to implement the Advanced Care Plan VA Group Visits Program. ACPGV is a diffusion of excellence gold status practice, and essentially what we do in ACP is provide a dedicated space where veterans and their family members can have in-depth discussions about planning for a future health care crisis. So we really emphasize the importance of completing the advanced directive, and we provide that space for the conversation to start for veterans and their families.
So I came into my position in April of 2020. When the program was designed, it was designed with the thought that people would meet in groups, kind of like we're doing now, sitting around at a table, veterans being able to talk to one another. And the thought was it would be in person. Of course, when I started, COVID had already reared its ugly head. And so we were completely shut down. And so we had to quickly pivot to doing telehealth or virtual appointments only. Last February of 2021, I was able to start doing some inpatient groups on one of our inpatient units with psychiatry patients. But Richmond has been very limited in what we've been providing or allowing as far as visitors, people coming into the building without appointments, things like that.
Salem has had a very different approach. We were offering advanced care planning prior to COVID, but all of those, like Erin said, all of those were in person because that is how the program actually was set up. But March 2020, when I stepped into the role, 2 weeks later, COVID shut everything down. And so at that point, we had a program that was based entirely on groups where we weren't able to have groups. And so we had to figure out how can we facilitate this program because it's so important in the midst of COVID. So for Salem, we were closed down and had to do virtual visits just from March 2020 to July 2020. And then I was able to start doing more of like a hybrid program where we had some in-person groups being offered, like in our residential units. Some of our mental health groups were in person at that point, but also still offering virtual options.
So I've learned a lot just being here in the last 24 hours about all the different telehealth options and virtual type stuff. Interestingly enough, the VA was had a lot of that in place. And the VA did too. But the VA already had its own platform called VA Video Connect, or we call it VVC. And so we already had that platform available. Not many people used it, but we started using that. So I feel like that was really beneficial to us in being able to pivot that. We also have used WebEx. We've used Teams as we needed to. Doximity has been helpful. I don't know if any of y'all have used it, but it's been helpful for people not having your phone number and still being able to trust that you're calling from the medical center. And then we're working on having a virtual medical care center, which is basically an avatar into the medical center. That's in beta testing right now.
So as far as some of the barriers that we encountered when we were pivoting to virtual, and it was really interesting that the providers had basically the exact same barriers that our veterans were having. So some of those barriers were just simply lack of internet, because some of their providers were teleworking at that point too. So we had veterans in our rural areas that didn't have access to internet, and the same with their staff. Lack of devices. So again, our rural veterans and even some of their more, really not a city, but more veterans located within Roanoke didn't have access to devices. Limited education and comfort using virtual modalities, difficulty problem solving any technical issues that came up during a meeting. And then just for staff, there were a lot of discussions about the legal and ethical issues of providing virtual care.
So some of the lessons learned is that although the technology was available, not everyone knew how to use it. Like Mira was saying, not all the staff or the veterans felt comfortable with it. We did have to get very familiar. We have a digital divide process at the VA where we can issue iPhones and iPads to veterans that meet certain criteria if they don't have internet access or they don't have a device. So using that, we found out when doing groups how important having a co-facilitator was, like to help with those technology issues that might come up and be able to, turn off their camera and call a veteran. And then we just learned how important it is to be flexible and to just kind of go with it and still want to serve the veterans and share your information.
So as far as the future state, and I think you all already know this, like, as far as we are in the place where veterans are really excited, want to come back and do some in-person visits. However, on the same token, we have a lot of veterans, especially those who are further out from the facility and our younger veterans who are like, we like having the convenience of virtual visits. And so even though COVID-19 and that transition to virtual was completely unexpected, it's definitely something that we're going to continue to use all those lessons that we learned from there as advanced care plan via group visits continues to have both the in-person now, but also strongly built on virtual visits.
We went over a little bit, but if we don't have any other speaker, Ms. Martin, will you come virtually? Okay. Yes. We do have some time left then. Does anybody have any questions for Brian?
I was just wondering how comfortable the patients were using the devices in the room. I'm thinking about WebEx and how that worked out.
So in the patient spaces, we didn't actually have WebEx. We used systems that were registered on-prem to our call manager, and we did that very specifically to have a high grade of control and security over those. We used WebEx because those systems were compatible to dial out into the WebEx units, and that's typically how we controlled that. Patients really became very comfortable very quickly. It was part of our standard of care within the spaces, and we really didn't get a lot of pushback on it. We made sure that it was clear when the system came on so they knew if it was being monitored or something was happening. But literally in a lot of these spaces, the systems were on 24 hours a day. I mean, these became, the iPad, the outside of the space, the people that were monitoring had them on and they were connected all the time. So the patient would just be able to speak and they were talking to the person outside the room. So it was a very high level of comfort.
Awesome.
Any other questions for anybody?
I have a question for our veteran group, or group serving our veterans. Have you looked at the age of the veterans? Because, I think we all think, when we think veteran, we think, the adorable, gentleman with his Korea hat or something. Right. I mean, my husband's been a veteran for 12 years and he's not an old man, right?
Yeah.
So
So it's interesting because our populations are so different. Being in Richmond, we have several bases near us, as far as Navy, Army, Marines, we have a lot of bases. I have a much younger population. I may have 20-year-old who had a medical issue and is coming out of the military. I have a lot more like middle age, 40-ish, 50-ish. Whereas Mara, her population is very different. She can speak to that.
Yeah, our population is primarily Vietnam era. So it's a very different conversation, I think, for air veterans than when you have newer veterans who are younger. And I think, so we struggled in Salem with getting air virtual program going. So I think, Aaron can speak on this, hers is more an outpatient, people come in strictly for the group. I had trouble getting that going. And so we do more of established groups. So stepping into like mental health groups, PRC, residential. And so it definitely is an older population. I think that impacted why we weren't able to get the sole groups that were solely ACPGB going.
Well, I think too, the older population sometimes has more difficulty with technology, but then the younger population is like, I don't need to talk about that. I'm 22 years old. I'm healthy.
Right.
And, so we talk a lot about like, we don't have crystal balls. Everyone has an expiration date at some point. We don't know when it is. But these conversations are important. And so we both had, I think, our challenges both ways. Populations not feeling like they need it, and then populations feeling like, I need it, but I don't feel comfortable with the technology. Thank you.
Any more questions? Few people virtually. Well, I'm gonna give y'all just a couple minutes.
Wait, what does
of your time.
Thomas's thing look like?
What's that?
So we just look at them.
Yeah, what's Thomas's poster?
Tracy also looked like that. And also, just a reminder, everyone's poster is online, and each poster presenter recorded a 1 minute, a 1 minute summary of their poster. So you can see Thomas online, and he'll give you a 1 minute quickie elevator speech on his presentation. The title is in the book here. Assessing payment parity using all payer claims, databases, post-pandemic legislation. He's with
St. John thing? So it has to use.
St. Joseph's, that's what it says. St. Joseph's University.
So just want to thank everybody for coming in and presenting and listening and asking questions. Because of our poster presentations being held simultaneously, reminder, go online, look at the other posters, and hear their short recorded talks. Don't forget, please vote for your People's Choice Poster Award via the virtual platform or the Agenda app. And with that, I'll give you all 2 minutes.
Thank you so much.
Thank you all.